All right, we'll go ahead and get started just so we're on time for everybody. Welcome, everybody. My name is Breanne Jacobs. I'm an assistant clinical professor of emergency medicine at George Washington in DC, and I work with Rita Manfredi, who unfortunately couldn't be here today. She had an operation recently and is still recovering, but she gives her regards. This talk is called Pearls and Pitfalls of Rapid Goals of Care Discussions in the ED. And the main talk is really about changing the paradigm of how we talk to people about what they want when they come to the ER, particularly if they have serious illness. From residency, we get so standardized on asking about, do you want CPR, do you want intubation? And we want to really change the way you have those conversations to be more patient-centered. We have no disclosures at this time. So our objectives, as you can see up there, is moving, again, as I said, the paradigm from our standard EM conversations that we all have to working towards a more patient goal-centered care model for talking about end-of-life care for patients. We want to talk about how palliative principles can enhance patient care and strategies to help our patients and us align a plan that's going to work for what they really want when they have serious illness and come to the emergency department. One point I wanted to make is I am not a palliative care physician. I work in the community part-time and I work in academics. I'm a just straight EM doctor, but I believe strongly in these conversations in the ED for our patients with serious illness, and I really think these are something that any ER doctor can have with their patients. You don't need to be a palliative care or a geriatrician. So the first thing we wanted to talk about is our standard EM care model versus patient goal-centered care. We teach our residents about patients with critical illness coming in, your patient with COPD who comes in every month with an exacerbation. You give them their steroids, you give them their nebs, you reassess, decide are they going to fly going home or are they going to come into the hospital? And really they want you to move towards those patients, obviously treating them, but also thinking about those patients and having additional conversations with them. If you notice they're coming into the ER more frequently rather than last year it was maybe every 4 months. This year now it's every month. It is really talking with them about why they're coming in, one, so much more frequently, and also what their plan is, what the end goal is. And we want to work towards matching what the patients want with their treatment plans. And we just want to reiterate that the best time to talk to patients about what they want for goals of care is not when they're coming in unresponsive, needing to be intubated, needing to be lined up and taken to the ICU. It's when they can actually talk for themselves or they're sitting with their family member and can really engage in the conversation. And that's really where we want the paradigm to move with patients with serious illness in the ER. So as I mentioned, who are these patients that we're talking about? It's all the people we see. It's that COPDer that comes in every month. It's that CHFer that comes in with fluid overload despite the fact they're taking their meds. Yes, people have had a CVA, they come back with a recrudescence of symptoms, but really it's anybody, and you all know them. You walk around the ER and you look at the end of the bed and you say, I wouldn't be surprised if that patient's not here in the next 6 months. Those are the patients we want you to think about and maybe work with your residents, thinking about, not just we're gonna treat you and help you feel better, but what's your goals? What do you want for this chronic illness that you have, and how can we help you get there? So why should emergency physicians do this? Well, we all know that a lot of our patients do not have primary care doctors, or they don't go see them, or they can't get in to see them because the next appointment isn't for a year from now. The primary care doctors are trained in having advanced care conversations with their patients, but unfortunately, a lot of times they have 10 minutes, they're limited to one complaint, and especially a lot of these elderly patients have numerous complaints, and getting to the goals of care conversation unfortunately doesn't happen. So this is definitely within our lane. Studies show that 80% of people have thought about having these kind of conversations with their doctors, but less than 20% have actually had these kind of conversations. And most people, when polled, say they'd much rather die at home than in the hospital, and yet we're still not having these conversations. So we are the point of contact with so much of the healthcare, with so many of the patients, and it is within our lane to be bringing these up with the patients that we see. And it's not that hard to do. We learned in medical school the steps when you're talking with a patient about changing their behavior. There you have the pre-contemplative phase, the contemplative phase, and then the action phase. And we can use those steps to have these conversations. Furthermore, we will get paid for our time for having these conversations, and that's very important as well, because we know everything in the ER is about movement, it's about procedures, it's about getting patients up to where they need to go, but also, as we know more and more in healthcare, getting paid for what we do is extremely important, especially as the Medicare reimbursement rates are going down. So it is a procedure to have this conversation with your patients. It does not have to be done by a palliative care physician. It can be done by a primary care physician, an emergency medicine physician. The criteria that need to be in the procedure note are: one, that you defined who the patient's healthcare proxy is. If it's the patient or a family member, you just write who that person is and the phone number. Are there limits to the patient's care that they want to set forth? And that you have had a discussion with the patient recommending a plan for goals of care. And you also have to write down the time you spent talking to the patient and also documenting. And generally it needs to be a total of 16 minutes to count as a procedure. But that's not just the talking to them time, that's everything. And you all know that we spend, in terms of preparing, talking, documenting, that 16 minutes is nothing. You could easily get to that. So that's an accurate measurement of the time spent for this. All right. So this is how you have a very quick goals of care conversation in the emergency department. This framework has been set out by Vital Talk, and it's been utilized among palliative care physicians in ICU for a long time and validated. The 5 steps are as follows. You reframe the patient's clinical situation. You let them know that something has changed. They used to come in last year, twice a year for COPD. Now they're coming in every month. They're on increasingly worse medications for heart failure, and they still have tons of fluid retention. You give the patient a headline. Your mom is very sick. I'm afraid she may not make it out of the hospital this time. You expect emotion and you respond empathetically. I'm going to talk a little bit more about that. You determine the patient's values and goals, and you come up with a plan that's aligned with those values and goals that shows the patient that you're listening to them. And finally, you recommend a plan of care. It shows that you're listening to them, but it also recommends how to move forward. So let's talk about reframing the situation. As I said, Mrs. Jones, you've been here 2 times in the past month with difficulty breathing. You've been on steroids for that time, and it's not helping. Why is this happening? What has changed, and what are your goals for moving forward? I'm afraid that you are getting sicker. The situation has changed. You give a headline. Your dad is critically ill with a disease called sepsis. That's a bad infection. I worry he won't recover this time. And just let that sit for a minute. You have to be very concise with your statement, but you have to be very direct. You stop talking. You let that absorb. They're not going to be used to that quite direct of commentary about their condition or their patient's condition. You expect they're going to become emotional because you've given them very, very hard news. Give them a moment to process it, which a lot of times the best thing to do is saying nothing at all and just being there for them. If they're emotional, that means they've heard you. They understand what you've said. Here's some phrases that you can use to show that you're supporting them in an empathetic manner and help them as they process this information. I can see this is overwhelming. I'm here for you. I can't imagine how difficult this is to hear. Your father is so lucky to have you as a wonderful daughter. Tell me more about your mom when she was well. Tell me more about your family. Tell me more. Those questions show that you care and you have empathy, but it also gives as you work through this, it's a temperature check. They're absorbing this information, and then you can see where they're at with it. And this is where you do probably the most important step with a patient or their family member, their healthcare proxy. This is where you determine, once the temperature has calmed a little bit from that bang of headline news you gave them, what matters most to the patient. We have made some important decisions about your mom's healthcare plan for the future. It will help me if I know a little bit more about what she's hoping for. What matters most to your mom? You're not asking about specific medical treatments. You're not asking, does your mom want CPR? Does your mom want intubation? Instead, you're asking, if she could see herself right now, what would she say? What would she want? Has she told you in her last 10 years what she enjoys the most? Is it spending time with her grandchildren? Is it working in her garden? Is it your dad's ability to still be able to go see the Yankees play in the stadium? Is it that she wants to be alive no matter what, even if it means being attached to machines? It's going to be different for everybody. And by finding out what the patient or their proxy wants and what matters most to them, you can move on to the next steps. So as I said, sometimes people say we've never talked about it, we don't know what dad wants, I assume just keep him alive, and then again, a transition statement. Okay, let's take a step back. If your dad wasn't intubated here, if he was looking down on this situation, what would he say about this? What would he say would be an unacceptable quality of life for him? Is it if he can't walk, he doesn't want to be with us anymore? Is it if he can't be at home anymore, they don't want to be in a nursing home, they don't want to be in a hospital? Find out what their goals are, find out sort of the temperature of the family and what the patient wants most, and try and work towards you giving a recommendation to the family. And so what a transition statement you can say is, so from what you've told me, your mom really wants to be at home. From what you told me, your mom does not want to be attached to machines. She wants to be able to be as independent as possible for as long as possible. And we want her to recover. We hope for a recovery. We hope we can get her back to where she was before she got sick. But we also want to make some plans of care to be in line with what your mom wants if she does get sicker. And you sort of cite back to them what they've said. Is what I'm hearing you say is your mom doesn't mind being in the hospital. She has to have some antibiotics for a while, but really the goal is she wants to be back at home. Or your mom she doesn't mind being in the hospital. She wants to be alive as long as possible, even if it means being attached to a machine. It's going to be different for everybody, but it's just reframing it kind of in plain language and not using like a menu list of options for them, which unfortunately some of the rhetoric around goals of care has moved to. And this is where, once you've talked with them, you've found out what matters most, you recommend a plan. People come to physicians asking for our expertise and recommendations. If someone has new diagnosis of diabetes, we recommend initiation of metformin. We don't say to them, would you like metformin or would you like insulin? Or would you like a little combination of both? We don't say to them, would you like an albuterol inhaler or a maintenance inhaler? Could you do both? And would you like oral steroids or not? We, with our training, recommend something to them, and that's what we should be doing with palliative care. But we have to gauge our recommendation based upon what they have said. So if they said, your mom has mentioned to me her most important thing, or you've mentioned to me the most important thing to your mom is to be able to get home. So what we're going to do is we are going to support her. We're going to give her medicines for pain. We're going to give her medicines for hydration. And we're going to give her physical therapy to work to try and get her back home. It sounds like she would not want to be attached to artificial ventilation for a long period of time. So what we're not going to do is do CPR or put her on a ventilator. did I get that right? And they'll say yes or no. They'll say, no, I don't, or tell me more about CPR and a ventilator. What does that mean? I mean, most people have watched TV shows. They understand some concept of being on a ventilator, CPR. They don't know everything that goes on in the ICU. And they'll give you feedback back if what you're saying is correct. A lot of patients, when we've had these conversations, so appreciate not being given a laundry list of check this box, you want CPR, check this box, you want intubation, because they don't really understand what that means, and they feel the onus is on them, and they want the guidance from the doctor of what is best for their mom or dad based upon the situation the patient is in at this time. But it's really important to ask, those temperature check questions. Did I get this right? And they will tell you. Sometimes you are going to get to, and I find this often, you can't get to a plan. You provide a recommendation. They say, no, I don't know. I can't decide. I need to talk to family members. I need to talk to friends. I'm just not ready for this. This is too much. Suggest a time-limited trial of artificial support. So what I'm hearing is your mom has been sick for a while, but she still wants to engage in active treatment for her COPD. So let's try 3 days on the ventilator. And then would it be okay if I have the palliative care team talk to you guys again? And then see what that. So that's sort of a segue you can give. And a lot of times, as we know from our medical school training about changing behavior, it's baby steps. You have one meeting and then give them time to process, give them time to think about it, have another meeting. And then at that third or fourth meeting, they might be ready to quit smoking or quit drinking. It's not always all in one session. It's just important to get the follow-up and the temperature checks and give them the opportunity to have a further conversation later and think about what you've discussed. So again, just to summarize, this is the ED method for rapid goals of care conversation. Reframe the situation, let them know something's different this time. Give them a headline, the patient is very sick. Expect emotion, respond empathetically, determine the patient's values. What matters most to your mom? That's probably the most important phrase you can take from this talk. Show them that you've listened to them by repeating back what they've said and try and come up with a plan that's aligned with what they've said. So the points to remember are think about having these conversations with your patients with serious illness, not just the ones that are coming in distress, because that's when you can actually have a very meaningful back and forth and find out what matters most to the patient and their families. Be succinct in plain language, give them a headline, and give them time to process what you said. Sometimes when they're processing a question that seems like cognitive, like, are you sure? It's not really a question, it's an emotional response as they're processing. And that's when you can say phrases like, I hope she does get better, but I worry that with the severity of her condition, she may not. I wish for a miracle, just like you. But let's come up with a plan in case she does get sicker. Find out what matters most. Use terms like artificial life support, allow a natural death. You can clarify with words like CPR, intubation if they don't seem to understand that, but you don't have to jump to those phrases. And provide a recommendation based upon what they said. You are the physician. Thank you very much. What questions do you have? Yeah, please. Oh, let me see if I can give you a remote, because I really want to.
Thanks. Just curious in terms of whether you have some sort of a way to clinically assess their level of awareness or wanting to have those discussions prior to having them?
So, yeah, I know that, in a lot of cases, like in the hospitals, they can, if they have any question about capacity or patient's ability to consent, they can like call for a site consult, and we don't have the time to do that in the ED. What I do is I'll talk to them, and I make sure the nurse is present with us, and then I'll ask the nurse, do you feel comfortable with that conversation I had, that he was with it. He what he said is reliable. And just to kind of get a third party, because they're very good, and almost always they say, no, I agree. Yeah, they were with it. And I've had them say, no, I don't think, I really don't think that conversation is something that we can hold our hats on. So that's one way. I would, go by your clinical gestalt. It's kind of like your gestalt about, is someone capable to consent for a central line for an intubation, or have you just decided it's emergent? So you do have that clinical gestalt room, but I think having a nurse present is a good way. And also then it helps you, because a lot of times when you put in the order DNR, DNI, you have that her or him as your witness as well to confirm the conversation. Please, yeah. So it depends on the state and it depends on the hospital. I work in 3 states, Maryland, DC, and Virginia. So, and it's really hospital specific. Some, basically, I just put in the order in Epic that says, this is the conversation we had, this is who was present, you put it in the comments. Some of them have a drop down like, what is the request, supported comfort care only, IV antibiotics, IV fluids, but no intubation. Some places, if I just put it in as an order, it's accepted. Some hospitals have a form that they want me to sign and then the nurse to co-sign as a witness. So it's kind of like for your, again, emergent consent for procedures, every hospital is going to be different. Does a patient act, in verbal consent, some hospitals say, oh, verbal consent is fine, a nurse was there to witness it. You just type in your note, verbal consent given, nurse is a witness. Other hospitals are like, no, you have to have that paper consent. So I think it varies from state to state, but I would go by your hospital standard. And if you're not sure, like if you ask the charge nurse, what's the standard of care here for making a new patient DNR, DNI, and they'll tell you they know for sure, especially so that the nurses can adhere to that protocol. Any other questions? Please. Sure, that's a great question. So I think it depends upon the patient and the venue. So when I work at the VA with residents, we have a lot more time because there's more staff and you're not seeing as many people turning over. So turning over the patients and the resident's responsibility is not like at a level 1 trauma center where they're managing the bay and turning over patients. So I think the context is important. When somebody comes in and presents a case to me and I'm like, what? They're back now again. I'll say, well, did they have an advanced directive? And a lot of times the resident didn't even think to ask it because it's not, part of our framework. They're just trying to, figure out what's going on and what, medications they need. So it's a lot of times prompting them. And a lot of times I find that they haven't had training on it. So I'll grab them, say, let's go talk and do this together and have these conversations. I think it's hard enough for us, fully attending physicians to say to someone, you're really sick, I'm afraid you're not going to make it out of the hospital. It's certainly very hard for residents to have those conversations. But the more they can be with us and witness those conversations, it helps them for their future practice, learn how phrases, the catchphrases to say and how they're responded to, and they kind of are able to formulate. Everybody has to do this in their own way. Some people are more direct than others. You need to get the phrases that work best for you and are still going to be very concise to the patient. So, at the VA, we do it a lot more because we have more time, and this is a perfect patient population for that. I wish we had more time in the trauma centers, but certainly if someone's very elderly coming in, and even if they're in distress to some degree, you still have, 10 minutes to get, before respiratory is going to come and set up for your intubation, to just find some sort of goals of care. Do they have anything? Well, I'll tell the residents, just let's hold on a minute before you get your tube out. Just call the daughter and just confirm that she knows the patient's here. The patient doesn't have an advance directive. And I think that people think oh no, we just have to intubate them quickly. You always have a couple minutes. The respiratory therapist and the machine is not there the second they come in. I feel like you always have a moment to just look through the records, find out if there's an advance directive. If not, make a quick call to a next of kin, see if it is even a possibility that they don't want their 96-year-old grandmother, intubated. And a lot of times I find when I do these, I just make the quick call, nobody's talked to them about it, and when you tell them, they're like, yeah, she wouldn't want that. She's 96. She would want just to be making sure her pain is controlled and that she's getting hydrated, but she wouldn't want to be attached to a machine. So it's sort of a nuance depending on where you're working, but I do think there is always time just to even ask the question. And like I said previously, planting the seed gets them thinking about it. So even if they do get intubated, they go up to ICU, it gives the palliative care team something to start with. Thank you very much. I appreciate you guys.